Hey everybody, Stuart here. How are you all doing? All right, again, we're doing a virtual program tonight, all right? And we have two patient advocates. One that's going to be asking questions, the other one that's going to be answering questions, and of course we have our doctor. I will introduce all in a moment. All right, again, my name is Stuart Schlossman. We are sponsored tonight by Novartis, Bristol-Myers Squibb, and Biogen, okay? Round of applause, virtual. Okay, great. Thank you for that, everybody. All right, next, let's get started on who's here tonight. So we have Dr. Samuel Hunter, all right? And everybody should be really happy that he's online. He's not just an MS neurologist, he's also got a pharmacological degree, okay? So he knows a little bit more about the pharmaceuticals. Can't say more about it than the other MS neurologists, but he just understands it a little bit differently, okay? Then we have Sarah Hudson Rand, all right? We have Sarah Hudson Rand, and there she is, okay? She's down below, she's up on top, all right? And I went out of sequence, but I can't help that. I got MS and I forgot. All right, so next we have Jill, all right? Jill Molberger is the patient advocate tonight. Sarah's a patient advocate, but Jill is going to be asking the questions to Sarah and to Dr. Hunter. All right, so I don't want to take up a lot more of your time. Again, I'm going to be on asking questions intermittently after Jill asks questions, and we're going to go back and forth, okay? So please stick with the topics, and let's get started. Thank you.
Hi, everybody. I just want to say at the beginning to please keep your answers short because we have a lot of information to cover in a short amount of time. So we're going to begin. So Sarah, can you tell us when you were diagnosed?
I was diagnosed in 2002 at 23 years old.
And how long before your diagnosis did you start thinking something was not right?
So about 2 months before my major episode that sent me to get information regardless, I had numbness and tingling on the left side of my face. So I'd gone to my doctor, and because it went behind my hairline, he knew something was wrong, didn't know what. But then in the follow-up, he had said just keep an eye on any symptoms that you might have. So that's what I did, and 2 months later, I had another episode on the right side of my body.
Similar one?
No, much stronger, much worse. And so it took the right side of my body, my leg, my arm, my face sagged a little bit, my shoulder dropped. So it was a really significant attack, that first one. I was on the heavy steroids, the IV steroids, and it took me about 6 months before I could get back to work.
Wow. Okay, and since that initial diagnosis, have you noticed any further progression?
It's hard to tell just because as I get older, different things are going to happen. And, so I haven't had anything significant enough to really make me go, wow, this is completely different from my baseline. I can tell that sometimes my thinking is a little bit harder. Sometimes I slur more, but that's no worse now than what it was before.
Okay, and Dr. Hunter, are you with us now?
Yes, I'm sorry. I was clumsy and hung up the phone when I went to unmute it.
Not a problem. Can you tell us what a relapse is, please?
Well, I appreciated Sarah's comments. It's nice to hear someone refer to it as an attack. That's what we used to call all MS relapses. They've tended to get milder. Very simply put, a relapse is an increase in disability that is well defined in time. A relapse does not mean the problem is going to get better. Sometimes it doesn't, sometimes it gets close, sometimes it goes back to where it was. And relapsing remitting MS simply means that people have well-defined new problems. It doesn't mean they go away. A remission means that it's stable.
Okay, and then what is progression?
So there are two meanings of progression. The first is disability progression means someone got worse. It doesn't say how they got worse. Most worsening in MS happens during a relapse at the time of a relapse. So people say, last March I had some problems with my legs and I didn't quite get back to the way I was before. That is a disability progression. That is not progressive disability. When a neurologist says progressive MS, he means someone who's getting worse so gradually you can't point to the time that it changed. You can only point to the time you had to change in how you did things. Like you had to start using a cane, or you couldn't walk so far without resting, or you couldn't work a whole day. So you can point to the consequences of the worsening disability, but you can't say when it was. That's progressive disability, but they're both disability progression.
Okay, great. Thank you. Can you put a timeline on that?
Well, in general, a relapse is something that lasts at least a day. Most of them last far longer than that. They are not temporary things that happen because people wore themselves out or walked too far or got too hot, or it doesn't generally include just fatigue or just some bladder issues. It's multiple systems in many cases, or a more severe problem in a single system. We can measure disability lots of ways if there are questions about that, but it doesn't matter which disability you're talking about, whether it's vision or legs or coordination or bladder or thinking. It's just harder to measure thinking and bladder problems than it is other things. So we tend to rely on other symptoms to show us that, and they're going to get worse usually over days or weeks and improve over weeks to months to a new baseline.
Okay, and in Sarah's description of her initial onset, and then they waited 2 months, and then she had another attack. Was that
so?
It's
relapse? It's basically when you get close together, it's sometimes hard to tell if it's a single event or two events. But generally, if it's completely different, we say the new event ended the old event, and you have a new event. And when they're coming right on top of each other so rapidly, it's while that's technically like progressive MS, it's also in younger people, it tends to be just really active MS. It's hard to have more than three relapses in a year. At that point, we just kind of call it 4, and we say, that people are getting worse all the time. Nowadays, we don't see that active disease as much. The average person usually has 1 or 2 at most new problems in a year's time.
Okay, so what I'm hearing you say is that you can actually progress without having a relapse then?
Yes, and sometimes it's hard to tell if people are getting very sick very fast what the pattern is, and it's less meaningful. If you're way out there on the bell curve in terms of the worsening of the MS, you can see people in a few months who have major walking issues, and it's very hard to tell what kind of pattern it is. It's just a very bad pattern. The average person with MS spends many years with problems that come and get largely better, and it's only after a number of years of that pattern they end up with more significant, slower, progressive disabilities that we tend to call secondary progressive if they started with relapses. There's some people who never had a relapse, and they can't point to when it began. Those we call primary progressive MS. And they can still have relapses. They're less dramatic relapses. They often aren't diagnosed with MS till they're really impaired because nobody was sure what was going on. The good thing is that all these patterns are treatable. Just because you have progressive disability without relapses doesn't mean you have rapid progression of disability, and just because you have relapsing MS doesn't mean you don't develop disability quickly. There are some people who every time they have a relapse, it's like a major loss of disability, and the related disease NMO that it's like we used to call very bad MS is every time they have a relapse, it's a major disability progression. They don't even get progressive disability.
Okay. Sarah, do you think that your MS has gotten worse over the past year, 2 years, 5 years?
Well, and that's the interesting thing with my story is the first 2, that initial numbness here and then the severe here, my neurologist really expected my course to be a lot worse than what it has been. But we started on I started on a disease-modifying therapy, like right away, and I have not had a major relapse in this entire time. I can't remember exactly. I think it's 18 years now, so no major relapse that just knocked me on my hiney like that first one. Now the memory and the recalling, things like that, I can tell are getting worse. And that's been within the last 3 years where I can tell a significant difference. I have had a cognitive assessment. So I'm thankful to have a baseline, because whenever I feel like this is starting to affect my daily life, then I'll be able to go in and kind of see where that difference is from where I began.
Thanks. Dr. Hunter, does everybody have progression or well, that's not actually my question. Let me rephrase. Does everybody show progression? So is there progression in every case of MS, and what can people do to slow that progression?
That's a great question. So the average person with MS has relapses and progressive disability later on, but everybody has disability progression except a tiny fraction of people that we call benign MS, who have minimal disabilities. They get diagnosed with MS as a young person, 30, 40 years go by, and they really have no limitations. This is less than 5% of people with MS. For practical purposes, everybody with MS has some element of progressive disability that occurs after age 40 in most cases, where they get this sneaky disability worsening, or it occurs after they've had a substantial number of relapses and they have some impairments. We don't understand that fully. It behaves a little bit differently as time goes by on MRI early. There's new things going on, and as time goes by, it tends to be more the old things that are changing slightly, and you can't see much going on, but people are still getting worse. So, and this is due to microscopic changes that we can't see well on the MRI scan.
So are there things that people can do that will limit their progression? Can diet help, or exercise? Are there any things like that?
Well, there are some things that help. Okay, the first thing we know this from studies that have been done of MS patients, and there are a few lifestyle things that really make a huge difference. And the most important thing is something not to do, and that's to smoke tobacco. And that is so unbelievably bad for MS. Basically, you can look up in a chart how long you're going to be walking if you smoke tobacco, because it's very, very powerful, pro-inflammatory, and that just destroys the brain. The other things are good things that help. Obesity has a little bit of an effect both on people's abilities. Having a big head actually seems to protect people. So some women have quite large heads and some men have small heads, but in general men have bigger heads. But men have worse MS. So you can't do anything about your sex. You can't do anything about how big your head is. Now, you can do something about your diet and your other lifestyles. And there's no question that exercise helps a lot. Exercise helps your thinking. Exercise helps your fatigue. Exercise makes your legs work better. It makes your brain rebuild. Now, you have a hard time exercising if you're really limited, but you can still do things. Any amount of movement, even thinking about movement, helps. As far as diet goes, what's a heart healthy diet is a pretty good diet, but there are some things that have been found that really make a difference in how the brain does. And the most important is a kind of fat we call omega-3 oils. These are found in certain fishes and in certain grains. And these omega-3s, the people who have a large intake of omega-3 fatty acids, they do much better than everybody else. Their brains don't shrink and they don't have as much inflammation. It's also clear that a modest amount of alcohol has beneficial effects. Medicines in the antidepressant family have beneficial effects on the brain. A supplement called lipoic acid has very beneficial effects. Vitamin D calms down the disease by about 50%. And then of course, all the MS therapies very powerfully protect the brain against degeneration, even if people are still having problems. So it's like your brakes on a downhill slide. You may not stop it, but you can slow it down a lot. And the benefit of everything is what never happens, or what happens a lot later. And we see that now because people are walking much longer than they used to with MS.
Great, thanks for that. I just have one quick question. You said smoking tobacco. Does that go for smoking anything?
Well, we would presume that smoking anything has negative effects. People don't tend to smoke as much marijuana as they do tobacco. People on tobacco are smoking for the nicotine, and vaporized nicotine appears very safe in other diseases. It hasn't been studied in MS, but it's not the nicotine that causes the problems with MS. It's actually the air pollution. And so I usually encourage people that if they want to use cannabis in some form, that they try to use it without smoking it. But a lot of people who use cannabis, they use a very small amount. And cannabis has some very negative effects on people's thinking. That's really quite profound. That if you use it a lot. Now, if you don't need your mind, you're not going to notice it. But if you need your mind, you will notice it. And
Right.
It has some nice pain relieving effects. Turns out that even Tylenol acts like cannabis. That's why Tylenol works. You just can't take enough of it to get high. Your liver would give up the ghost first.
Okay, thank you. Stuart, I'm going to switch over to you. Do you have any questions coming in?
I do.
So thank you for that. So it's oddly that you were mentioning about the Tylenol, because we actually had a person ask if they can get a vaccine if they take Tylenol every day.
Oh, that's a good question, but there's absolutely no problem. In fact, most vaccine trials, they tell them to take Tylenol just to reduce any side effects before they give it, because physicians pass out Tylenol because it never causes stomach ulcers. And Tylenol, or acetaminophen as it's called in the U.S., abroad in the rest of the world they call it paracetamol. It's all the same thing. But it was only a few years ago that we actually learned that it actually works because a very small amount of it becomes something that looks like the endogenous marijuana compound that's in our brains, and that's how it has its effects.
So you're mentioning that, and now I have to think back to a lot of the people that use that take different infusions that they're asked to do, like a Benadryl and Tylenol prior to the infusion. So do you think that it's possible that to reduce any side effect flu-like symptoms from getting the vaccine, that it might be beneficial to do that as well?
Well, it would be predicted to be, and anybody who has significant problems with prior vaccines, I usually just tell them to take both Tylenol and either ibuprofen or naproxen if they can take those, because they're very powerful at reducing pain. Just the sore arm alone from a vaccine is a problem for some people. But what the symptoms you have after you get a vaccine are the immune system going to work, because it immediately recognizes that something's here that's not supposed to be here, and it elaborates a number of messengers we call cytokines that are basically chemical communication to the other cells in the immune system, and they all turn on at once. They make a couple hormones, one called interleukin-1 that makes people very tired and sleepy, and the other called interferon beta, which you will recognize if you've ever taken Rebif or beta-seron, Aminex, are these family of drugs, because they are all interferon beta, and they are what your body's first line of defense is against viruses. It turns on the signaling, and it makes people feel tired and listless and achy. That feeling, I'm going to have a virus tomorrow, that is interferon beta.
Okay, thank you for that. Now I'm going to ask that you try to just somehow get to shorter answers. I know it's hard to do at times, but we just have so much to do. I can't do that to you. Everybody will get angry with me. Everybody that's watching is going to say, Stuart's got to stop doing that to the doctor, all right? But for everybody to know, first, I know Dr. Hunter a very, very long time. We've had many dinners, and he and I could say what we want to each other, okay? All right, let me, exactly. Let me ask a question that a person has for Sarah, all right? Has Sarah been on the same DMT the entire time? And can she disclose what kind of DMT she's taking? I'm going to say no to that. Just let them know, though, if you're on the same DMT the entire time.
Okay. I wasn't. So I had started on a therapy right away, and then I've had 2 children. So both times with those children, I went off of meds and then went back on. But I had stopped taking anything maybe about 6 or 7 years ago. I had shot fatigue and I was just kind of done with that process, but I was too scared to go to a pill form just for various reasons. I had educated myself, but I still had my own doubts. And then whenever COVID started, I wanted to protect myself in every way. I think COVID kind of really gave my mind an opening and saying, I have 2 children and I need to start getting into gear. And I'm in my 40s now. I can't be childish anymore. And so I talked to my neurologist and we started a therapy right away.
Okay, great. Thank you for that. Now, for everybody to know, the reason why I stopped Sarah from answering about her DMT, this program is not about the medications. So if anybody's asking questions about medications, please know that we're not going to ask them. All right. Now, as far as the medications and the vaccines go, we're not answering that until at the end. So I see one person just asked a question about that. Again, please don't ask any COVID questions until we get to the third part of this program. Okay, I appreciate that. All right, so the next question from the audience is Renee is asking how much alpha lipoic acid is effective. And another person is asking, just so we could get this all under one umbrella, another person is asking if they can take omega-3, if it's as beneficial to take as if eating real fish or not. And obviously this is not for Sarah, this is for Dr. Hunter.
That's great. Alpha lipoic acid, the dose that most people take is 600 milligrams twice a day. It's usually sold as a 300 milligram capsule. As long as your stomach doesn't have problems with oily things, it's just an oil, just like vitamin D usually is. As far as omega-3, the studies have been done on intake. And they've been done both just measuring from all sources of omega-3s, because there are certain grains that have omega-3s, but cold water fishes, herring, salmon, tuna, cod, and sardines are the kind of fishes. We call them oily fishes. They feel oily when they're warm. And those are the fishes that are loaded with it. There are a few freshwater fishes, including trout, that have it, but most freshwater fishes don't, and most other fishes don't. So, but you can get them from fish, or if you don't want to eat fish, you can take them as a supplement. They even make from krill, which are actually shellfish. They actually even make products from shellfish, and for people who are vegan, they make products that are from that are omega-3 that are from grain that you can get as well.
Okay, great. Thank you for that. Another person writes, how much calcium and vitamin D3 should they be taking? And short answer, please.
There isn't a simple answer. It depends on how low your vitamin D is and what it takes to get to an optimal range. Most people will start with 4,000 or 5,000 IUs, which is 100 or 125 micrograms of vitamin D3. Some people with time can take less than that. Some people need much more than that. So I recommend people get their vitamin D level checked. That's 25-hydroxy D. That is the standard vitamin D test. They get it checked in the winter, like after the new year and before April, because that's the lowest time of the year. Because you get lots of vitamin D from the sun. Even if you wear sunscreen, you get lots. You get thousands of units a minute out in the sun. So if you get plenty of sunshine, your vitamin D level will not usually be too bad, but it's highly genetic, and you want to get it regulated to where it's an optimal level. The people with levels of 25-hydroxy D over 50 nanograms per mil, which is the U.S. units. If you're listening from Europe, it's a different unit there. It will do the best of everybody with MS. In fact, they usually do spectacularly well compared to the people with low levels, under 20.
Okay, great. So just so everybody knows, I live in the great sunshine state of Florida, all right? And I still have to take tons of vitamin D. So, you know, I guess we'd have to live closer to the sun for this to work as best as Dr. Hunter would like. All right, next question. I'm going to ask only 2 more questions from the audience, and then we have to get back to Jill as we have a lot to be asked to the doctor and Sarah, okay? All right, the next one is... all right, so is there an alternative to steroids for an MS attack?
Yeah, the answer is, I assume that's for me. The answer is
Yes.
the alternatives to steroids are milder ones you can wait out that aren't real bad. The reason why somebody can't take steroids is important because there are many ways to address the side effects people get with steroids. Very few people are truly allergic and you can't do without it. There is another drug called ACTH, or it's sold as Actar gel in the United States. That was the first drug that was approved for relapses. It has a very different side effect profile. It is much harder to get and much more expensive, but it is available for those people who truly can't take steroids. And then the other things that are used for relapses are only for extremely severe relapses, life-threatening relapses, and those are plasma exchange, which is the same as donating plasma. It's called plasmapheresis. It's done usually over a couple weeks, often in a hospital or in a specialized center, or IV immune globulin in rare cases.
Right. Thank you for that. So Kim asked that question, and one more from her, and that's because you were talking about side effects to the steroids, is that she says she's type 1 diabetic, and will the steroids, she's said that it can cause her harm.
Well, actually, they don't cause you harm. They just make your blood sugar go up. And type 1 diabetics are usually very good at managing their blood sugar. So if I have a type 1 diabetic come in, what I do is I give them a lower steroid dose. We usually use 500 milligrams rather than 1,000 milligrams. And type 1 diabetics are usually so well trained at managing their blood sugar that they have no problem dealing with that. You just have to do what you normally do, which is check your blood sugar before every meal and in the evening and give yourself the appropriate amount of insulin.
Okay, thank you. All right, one more, and that is that I'm trying to get to. Okay, so a person wants to know, and sorry, Sarah, this is not for you. This is for Dr. Hunter. All right.
Okay.
Actually, okay, well, let's go with Sarah first. How did Sarah go for? How did pregnancy go for Sarah, considering her DMT? Short answer I need.
All right, so I went off the DMD. I was fine. We set up everything before the pregnancy just in case. We didn't know what was going to happen. So we knew we were set if anything did, but thankfully nothing did.
Okay, great. Thank you for that.
Pregnancy.
Great, thank you for that. And for those that have had MS for an extremely long time, they are known as DMDs to us, disease-modifying drugs, and everybody else in the newer world of this illness, I'll call it a DMT, which is a disease-modifying therapy. All right, so that's the difference. Stanzi, who asked that, he asked for a DMT, and it's Sarah answered as a DMD. It's the same thing. All right, last one for Dr. Hunter. How much omega-3 plant-based algae oil, 630 milligrams DHA plus EPA should I be using?
As much as you can afford. As long as you don't start smelling like fish, you're okay. And you can also get it just from your diet. If you don't want to buy supplements, there's certain grains that have a lot. Flaxseed has a lot. Flaxseed oil has a lot. You just need to look up what's a easy way for you to do it. But there are natural ways to do it.
All right, thank you for that. And for everybody, listen, there's a lot of topics, a lot of questions that are being asked that we cannot answer tonight. But please know, if you go to our YouTube channel, everything about multiple sclerosis has been covered. All right, everything about multiple sclerosis has been covered. And especially in the last few months where we're doing a tremendous amount of virtual programs, it has been covered. So all I'm going to ask you to do is go back and go to our YouTube channel. You could visit it from our website, blog, e-newsletter, or anywhere. If you can't find it there, you could always ask me, and we will give you the login information. All right, we have to get on to the next topic, all right? Jill is going to be following up with getting into MS symptoms, physical and cognitive. She's got to do this and grill the doctor and Sarah for about 10 or 15 minutes. Then we'll take some questions, and then we're going to get into the hot topic of the night, okay? See you all soon.
Okay, my turn again. As Stuart said, we're going to talk about MS symptoms, both physical and cognitive. So Sarah, can you quickly tell us about your symptoms?
Well, starting out, I had the severe numbness. Now it's just kind of numb on my hand and my leg. I have a constant hum. I don't really hear it during the day so much because I'm busy doing other things, but whenever I go to sleep, then it kind of, it's more noticeable. Like I said earlier, the slurring of the speech, I'm kind of noticing, and we're kind of watching on a little bit of a sag on the left side of my face, to see if that's what's going on with that. And then really just the cognitive issues. I really noticed that I started a new job this year, and just being around other people, I'm hoping will spark some of that back into my mind. But that's all I notice now.
What kind of cognitive issues? Can you describe that a little bit?
Not so I feel like I always know what's going on in my head, and then whenever I go to kind of regurgitate what I'm thinking in my head, it doesn't always come out as smoothly as what it is in there, if that makes sense.
A loss of words, or just not able to connect the content?
Not able to connect the content, really just kind of choppy thinking. It seems almost hard to speak and think at the same time sometimes.
That's interesting. Okay. Dr. Hunter, can you comment on that at all?
Well,
Sarah's describing?
the most common symptom people with MS complain about is fatigue. The second most common is the sensory changes. The third most common is a visual disturbance of some kind, and after that, it's clumsiness or gait problems. And then you get into a laundry list of things that are still quite common, like bladder and bowel and sexual dysfunction. All kinds of other uncommon things, certain sorts of pain and difficulties. With other aspects of the MS, balance, vertigo, all these things. The top four that would be sensory problems of some kind: vision, sensation in the limbs, and vertigo, and then fatigue.
Okay, great. Thanks. I have a question here about foot drop. Can you talk about what foot drop is?
So foot drop happens for a lot of reasons, not most of the time, but only MS. And in MS, foot drop happens for two reasons. It either is because you have a hard time lifting your toes because they're weak, or you have overactive muscles that are pushing your toes down because they're spastic, is the term we talk about, which is what you see happen in people with the damaged nervous system. Muscles turn on and won't turn off. And so the big muscle wins. And so the foot can go down either because it's pushing itself down, or it can fail to come up because it's weak. Either one, and they're treated differently, but both of these are foot drops. When a foot is really weak, it just kind of slaps on the floor when you walk, and you have to lift your leg up higher so it won't do that. But people have to do that if their toes won't come up. They may have to shift their body weight so they can bring their leg through so their toe doesn't catch.
Great, thank you. I have some people asking about lower body nerve pain and what that can be, or what they can do about that. Do you have any thoughts on that?
So people with MS get lots of unusual pains, which we usually ascribe to damage in the nervous system. The term generally is called neuropathic pain. It's not a neuropathy technically. A neuropathy means there's something wrong with the nerves. Well, in MS, the nerves are actually fine. It's the spinal cord and the pathway to the brain that's not normal, but it's the same type of pain. Pains that are unnatural are often neuropathic pains. People may describe them in many different ways. They may be burning, stinging, tight, touchy, achy. It depends on what it is. And the character of the pain gives some hints to physicians on what might help make it better. Many times there's 3 or 4 medicines that are given at once. Generally, nerve pains in MS, the best way to treat them is to completely avoid narcotic medication because it often makes them worse or harder to treat. And there are many non-narcotic strategies that work well. There are also some, other than medications, there are actually things like balms and electrical stimulators that we call TENS units that actually do help many people.
Sarah, have you tried any of those kinds of things for your tingling or humming?
Yeah, and I said it will kind of come and go depending on my fatigue level and what's been going on in my world. I have other sensations that, as we're talking about this, I just remembered where I will get sharp burning pains on and off though. So it's not a relapse, but it's there. And so I've gone to physical therapy. I've done some acupuncture. I've swimming in the summertime. I didn't notice it as much. And so it kind of changes with each episode and each time, each different sensation and how I have to go about kind of finding relief or just figuring out a way to get over it.
Do you ever question about whether it's MS or whether it's an orthopedic issue?
Well, whenever it comes to some of these sensations, it just feels like it's a nerve sensation. And I've tried so many different things to stop the pain, and the fact that it comes and goes intermittently is different. So maybe it could be. I'm not the neurologist, and so whenever I see my neurologist, we talk about it, and we'll try a couple of different things, and if it works, so maybe that's her way of telling me that it's orthopedic.
Maybe.
Maybe.
Do you find it interferes with your daily life, or are you able to push through it?
Whenever it was my arm pain, it was really difficult because everything that I do is with my arms, and I had limited access, limited mobility. It was really frustrating and just really fatiguing not being able to do what I wanted to do. And so with that, I had to throw a whole slew of different things at it. So whatever it was that worked, I don't know, but eventually the pain eased up. Sometimes I can feel it coming back. I just keep my fingers crossed that it won't be as long term as what it was before.
Right.
So maybe
And
that was a relapse and I just didn't get it checked out.
Maybe.
Yeah.
Okay, I have a question, Dr. Hunter. Can you describe what the JC virus is?
Okay, that's a good question. Viruses are us. So JC virus is named after an important individual, and if you ever see it called by the gentleman's name, then that whoever is using that name is not only inappropriate, they don't know what the real name is of the virus, because it's not John Cunningham virus. John Cunningham was the unfortunate soul who gave his initials JC to the virus, and it's not Jesus Christ, and it's not Jakob Creutzfeldt, which is a completely different disease. That we changed the name to Creutzfeldt-Jakob so people would stop getting them confused. The JC virus is an innocuous virus normally. It is a virus that almost everybody gets, even if people think they haven't had it or the blood test says they haven't had it, they probably have. Because it's ubiquitous, it's a harmless parasite that lives in our bodies our whole life, unless you have a very weak immune system for a very long period of time that doesn't control the virus. And so the virus that transmits from person to person is completely benign and never causes trouble. And I won't go into the details of how it gets from person to person because it's not very sanitary, but it's everywhere, so everybody gets it. Now, this virus, when it gets out of hand, when the body isn't controlling it, it makes mistakes in its replication that allows it to mutate into a form that can grow in the brain. Now, this is not a problem as long as you have an immune system to go hunt it down and to get rid of it. The problem is when your immune system is not doing this job, this multi-step process that goes on over many years leads to a state where the virus can grow in the brain and the immune system is not going after it to stop it. And it causes an infection that we term PML, or progressive multifocal leukoencephalopathy, which is the old term before they understood what it was. And this happens very rarely with every condition in MS except for one, which is people taking Tysabri, which is so effective at keeping the immune system out of the brain and activating this virus that a small percentage of people will get this infection in the brain, which is a life-threatening, life-changing condition 100% of the time when it happens, essentially. And so we try to avoid that. That's the only downside to this very effective other medicine. It's why it's not used very much. But it does happen with some other powerful MS medicines, just much less frequently. We're talking about the difference between 1 in 100 and 1 in 10,000. with other medicines. So it's literally 100 times less with other MS medicines. And so it's not an issue most of the time. It does happen, this disease happens in other immune diseases than MS. It happens in a number of cancers where people don't have a very good immune system. But it's a problem only in people in Tysabri for practical purposes. When it happens to anyone else, it's like getting struck by lightning.
Great. Thanks for that answer. Okay, we're going to switch over to Stuart. Do you have any questions, Stuart?
Do I have any questions? Oh my gosh, where have you been? Of course I do. All right, first one for Dr. Hunter. Lermeets and MS, is there anything that can help?
Oh, yeah.
This is from Aurora.
There's medicines we have that if we show you the bottle, it will go away. So Lermeets phenomenon, Lermeet was a doctor, okay, and you can look up online how to spell his name. But he was the doctor who described the symptom that when you bend your head or move your neck, that you get an electrical-like sensation in your body. It can be sudden and jolt-like, or it just can be tingling. It also happens in people who have orthopedic problems in their neck, not just MS. But the medicine family that works very well is related to Tegretol or carbamazepine. There's a related medicine, oxcarbazepine. Phenytoin or Dilantin also works. These three medicines will make it disappear almost completely, very reliably. Those medicines also work well for stinging and burning pain and for some kinds of spasms that are very frequent, that are called tonic spasms that happen regularly. They're all due to short circuits in the nervous system. When there's pain, it's inflammation moving up. When there's spasms, it's inflammation moving down. And just like this medicine's used for a facial pain called trigeminal neuralgia that does happen in MS, it works for these other conditions too. And as I would say, if we show you the bottle of that medicine, it works so well that the pain will go away.
Great, thank you for that. You have a question?
I do. Well,
You're out of line.
may I?
Yes.
Thank you. For someone like me who is really hesitant on starting new medicines, just so if the benefit is there, are there any risks to those types of medicines? And I know I'll talk about that at a later point, but are these meds generally safe?
Yeah, actually, they're really safe for children to old people. The one that's most commonly used in our clinic now is oxcarbazepine, which used to be called Trileptal. And very small amounts will sometimes work quite well. It's a very safe medicine. It doesn't interact much with other medicines. As far as any side effects, anybody could be allergic to any medicine, but other than that, that doesn't keep most people from snacking in a nice restaurant on things that they haven't tried before, and it shouldn't with medicines. But it's a very, very safe, cheap medicine now that we use. It can, in some people, especially older people, at higher doses, it makes their body hold on to water, which causes a condition called hyponatremia, which dilutes your blood. But that is very easily dealt with and detected.
Thank you for this. All right, so going forward, Michael would like to know how would foot drop affect gait? If you can please give short answers, we got to get on to the next topic shortly.
Well, imagine trying to walk without being able to lift your toes. That's how a foot drop affects your gait. You have to lift that side of your body more. You either have to bend your knee to lift your leg higher, or you have to tilt your body to the other side so your foot comes up. And depending on whether the foot drop is a spastic foot drop or a flaccid foot drop, which means it's weak, depends on what exactly you do. People who have a lot of weakness also have a tendency to sprain their ankles. We usually put them in a brace called ankle foot orthosis to stabilize their ankle. That both helps them do some things with their leg, and it protects their ankle joint from getting damaged.
Great, thank you. For all asking questions relating to COVID, I have to ask you again, please wait until we get to that topic, okay? It's going to get lost in the transition of all the questions that are coming in right now. So please hold your COVID questions to the end when we get to that topic and ask again. Otherwise, it'll get lost here, right? Also, please remember, everybody, anybody asking specifically about medications and their side effects or what might be having nothing to do with anything of our topics tonight, we can't answer this. This is not for tonight's program. It has been spoken about a zillion times in the last year and before that. Okay, so I'm sorry for that, but we just can't get into that tonight. Next question. What helps with the MS hug? Okay, and this is not just from Melissa, but this has been asked by a lot of people tonight, and so I've got to make sure to ask you this.
Well, let me explain what the MS hug means for people who don't understand. So people who have spinal cord problems get an abnormal sensation around a limb or their trunk that feels like something's wrapped around them or tight. And it can range from just an annoying sensation to an extremely distracting and painful one. There are lots of things that help. There are multiple families of medicines and physical modalities. You need to try different things. You need to try combinations of things if it's really bothering you. The families of medicines, very simply, we just talked about the carbamazepine family. That's one of the medicines that sometimes works. What we call gabapentinoids, which are either gabapentin or pregabalin, works for some people. SNRIs, which are medicines in an antidepressant family that relieves pain, which is duloxetine is probably the most commonly used one, works for this. Tramadol, when it's particularly painful, is a non-narcotic painkiller, which is regulated like a narcotic, but it is not a narcotic. Works for some people. People who have seizures can't take tramadol. And then a transcutaneous electrical stimulator, what's called a TENS unit, you can buy them for $30 online. Now they cost much more than that in pharmacies usually, but those work quite well for some people. So do some balms, sometimes Blue Star, Icy Hot, BioFreeze. Sometimes you put those above the level at which you're experiencing the sensation. They often help.
Great, thank you for that. We're going to cut back now to Jill. We are approaching a mark where I'm going to have to ask Dr. Hunter if he could stick around a little bit longer, only because we have another. Great, I'm glad to see that. Thank you very much. Sarah, I hope you could join us as well. Everybody, we have over 120 people online. We have a lot of questions coming in. Dr. Hunter has just agreed to stick around for longer because we have a topic that has to be discussed before we get into. We may have a couple of topics to get into before we get to the COVID. All right, so Jill, you're up. Take it away. Take it away. Take it away.
Okay, we're going to talk about understanding MRI and brain health. So, Dr. Hunter, can you tell us how MRI is used to determine disease progression?
Well, MRI, the first thing we do is we try to find the alien implants and remove them. But no, just seriously. MRI is a revolution in caring for MS. We learned so much about it. But how we use it is to look at the part of the brain that we can't easily examine. We use it early on in MS to see where the lesions are. But later on, we use it to look at the silent area of the brain, which is called the cerebrum. It's your noodle, the huge area of your brain above your ears that processes information. This is where much of the disease goes on that we don't notice. So we use it like a canary in a coal mine to see what's happening that we don't notice. Because most of what people do notice is outside the brain areas that we're looking at with MRI, which is up here. This big area, it has to be an enormous problem for you to notice it. In the input-output pathways of the brain, the eye nerves, the brainstem and spinal cord down here, it's harder actually to see the lesions on MRI than it is to measure them and notice them, what they're doing. So it tells us very important things. And so people can have things they notice that you don't see on MRI and vice versa. A lot of what's seen on MRI is actually old or things that you never noticed happen, but they still do damage to the brain. So we can measure the number and whether there's new lesions, and we can measure the size of the lesions, the volume, because it's a three-dimensional way of looking at things, and how severe they are. They can be milder, that they just scar the brain, or they can just basically make the brain evaporate inside the lesion, and they produce what's called a black hole. So all these are ways that we use to manage, and then we also, with MRI, can look at the volume of the brain itself, the size of it, because most people, by the time they know they have MS, they've already lost much more brain tissue than other people their age.
Okay, thank you. Does the location of the lesion correlate to a particular disability? If I have a lesion here and Sarah has the same lesion here, will we have the same disability?
In most cases, people have no obvious disability from the large area of the brain that they notice particularly. That is not always true. If it's large enough and happens to hit just in the right place inside the brain, it can make you very weak on one side. It could cause you to be very numb on one side. It could cause your vision to be bad. If it's in the front part of your brain, well, pretty much right up here, this is where you live. You live there. That is where you reside in your brain. That is your personhood is there. And lesions in those areas can affect your mood or your judgment or your ability to tolerate things going on in the world. Like you can get very upset or very depressed, or very anxious from things in that area of your brain. But in general, you don't. So things are very unnoticeable. The way most people experience problems inside the larger area of the brain is their thinking's a little fuzzy and slow. And your thinking can be fuzzy and slow even when your brain looks normal with MS, because it goes on at a super microscopic level with the changes that result in that. The same as somebody hits you on the head,
Right. Sarah, when was your last MRI? Do you know?
Last MRI was about 8 months ago.
Okay, and did you understand what it was saying?
Well, I always request to have a disc of my MRI whenever I go to get it, just so I have it for record. And I'm sure I could go back through and call, but it's easier to have it with me and in my file. So whenever I look at my MRI, I've learned over the years that I am not a trained professional, and I have no business trying to read my own MRI because it just keeps me up at night. But it is fun trying to find little squirrels and aliens in the MRI and show the Facebook world, this is my brain. I don't know what it means, but this is my brain, and it's kind of cool.
I can understand that. Okay, I'm gonna read you guys a definition that we found about brain health, and then I have some questions. So brain health is a person's ability to function well in daily life and work. This includes making wise decisions, solving problems, interacting successfully with others, and enjoying an emotional balance. So Sarah, do you notice or are you aware of any problems in your daily functioning relating to your brain health?
I would say yes, like communicating with other people, the employees sometimes is different, and it's just really awkward feeling. I would really like to learn more about tips and suggestions myself on how to overcome that.
Okay, well, Dr. Hunter, here's your chance. How can we improve our brain health?
I think the best thing you can do is what your grandmother told you: eat right, get exercise, and get enough rest at night. Those things are very helpful. I think in a positive mental state, seeing the glass half full, counting your blessings rather than your curses, is a really important thing. You program the view that you have on the world in part by how you think. And it really does help to do things like mindfulness and to think and meditate and to think on the good things, think on beautiful things, hear beautiful sounds and music, see beautiful things. They make the chemicals in your brain that let you think clearly go up. And so do all these other health habits that are so useful. Being around helpful people, kind people, helping people, children, seeing beautiful things that make you feel like what it is to be alive are going to help your brain work better.
Do you believe in any complementary therapies?
Lots of things work. I mean, these things work. When it looks like what really works well for MS, a little bit of alcohol, fish, exercise, good rest, and being around people. Those are the things that really make a difference. Of course, I talked about avoiding tobacco earlier. That's so important, it's beyond belief. Don't even breathe other people's smoke. It's important. But as far as complementary things, people do things because they make them feel better. Chiropractic makes your spine feel better, but so do lots of other kinds of manipulation and a inversion table. Acupuncture makes you feel better, but there are lots of ways to get the same effect that don't cost that much, like a stimulator or a massage or a vibrating massager. These things all work. As far as anything that's really cheap, I think that there are lots of things that are helpful. If it makes you feel better and it's harmless, it's fine. I'd rather people do those complementary things that get in to see somebody who's going to give them really bad medication that isn't helpful. But most medicines that are approved and been around a while are very safe and effective. They're tools in your toolbox. You don't have to take them, but it's helpful to try them and see if they fix the problem.
Sarah, have you tried any complementary therapies?
Well, I've tried the chiropractor, where you put the needles, acupuncture. I've tried that. I've tried a variety of things. Nothing that I have really gained consistent strength on. I try to meditate. Everything that I do is in a constant practice, but I still try to follow some guidelines that I put out for myself.
Okay, great. We're going to see if Stuart has any comments from anybody.
So again, we always have questions and comments. And so we are going to, first off, I have to just step back just one moment. There was a person that asked a question before that I didn't ask it. And again, this is a question that just so many people ask. I just want to make sure that this gets in here. Dr. Hunter, so the person writes, his name is Mike. I have spasticity that only happens at night. And I hear about this constantly from people. Me, Stuart, I only hear this constantly from people. But this person writes, I'm taking 10 milligrams of baclofen, which helps a bit, yet like after 4 a.m., it begins again. So how many milligrams of baclofen should he actually be taking? Is this a question that you can answer?
Yeah, I'm not licensed in most states, but so this is my answer for people in Tennessee. Anyhow, so there are different kinds of movements. Spastic movements are associated with stiffness and weakness in a limb, and they tend to be worse when people straighten out their body, whether they're standing or whether they're lying flat. And baclofen 10 milligrams is a really, really small dose. Many people take as much as 4 to 6 times that in an evening because it doesn't last very long. There's also another highly effective medicine that works well in the evening that's called tizanidine. And tizanidine has been tested also in very large doses at bedtime. And they will last through the night. And while tizanidine is a more sedating medicine, baclofen doesn't last very long if you need the effect all day. Tizanidine doesn't last very long. Hopefully there was approved today, I haven't seen the newspaper, a new form of baclofen that lasts much longer than the other ones. But the important thing is it's very dose related, and you want to get the dose up. And the other thing is that's mistaken for spasticity sometimes in people with MS is a more common problem called restless legs that is a big deal at night, where people feel like they have to move their legs. Their legs jerk a lot, both before they go to sleep and after they go to sleep. That's treated with a completely different family of medicines. Many people have both problems.
So isn't it also safe to say, though, that a person that has this leg spasms at night, that using gummies, medical marijuana would be good for that person?
Well, cannabinoids do make it better, but they also have side effects. And so everybody knows about reefer madness. If you take enough, a lot of people with MS get reefer madness. And that's, even at relatively low doses of 10 to 20 milligrams a day. But it's not harmful if you're not responding to anything else and it's really an intractable situation. those medicines are actually available in some cases by a prescription from a neurologist. We rarely will do that because it's only approved for intractable nausea. We try to limit ourselves to that situation. But it is, you can use, if you're in a state where marijuana is legal, you can certainly get it and try it. It's just side effects. You got to balance side effects and risks. There is a spray that's available in the rest of the world called Sativex that's actually quite effective for people with severe spasticity. It's available in Canada and Europe. It's the FDA, as in their usual way, has their own way of doing things, and it's taken 15 years so far, and it's not close to getting approved in the United States. But it will be someday.
Thank you for that. So the next person writes, can high-power MRIs see gray areas?
Well, can a high-powered car win races? The answer is yes. If it's driven right and the person who's looking at it knows what they're seeing. You can make very bad MRI pictures with a very expensive MRI machine and run people through it in 5 or 10 minutes and charge them a lot of money and make a lot of money. It's very important. There is an internationally agreed protocol called the Consortium of Multiple Sclerosis Centers Protocol. And if the center you're getting MRIs at is not doing that, or says, what is that, or we have our own way, it's not the best way. This has been established 20 years ago, and it's been modified several times. It's online at mscare.org. If you search protocol, you'll find it. Give it to your doctor. Insist you have it done that way. If they say, no, we don't want to do it that way, find somebody else to do it.
Great, thank you. Now, another thing is that CBD and versus medical marijuana. Can you let people know the difference of this and all the different grades of CBD?
Okay, well. There's sometimes what it says on the bottle isn't accurate, but so this is hard because you have to go to good people. If you've got a friend or a reference that has a very good one, or a very popular one, it's probably better made. Now, so hemp, which is cannabis, has oils in it that are of differing characteristics. And marijuana is a kind of cannabis that has a lot of THC because that's the psychotropic agent that people use when they want to get high. Now, THC also has some benefits. It's available as a drug. Doctors can prescribe it. It is the same chemical constituent. Marijuana has multiple chemical constituents. The other very common one is called cannabidiol. All these resemble some normal pathways in the brain that the brain uses to regulate mood. And so THC is the intoxicating one. In most CBD preparations, where CBD is not an intoxicating one, in fact, it's a very benign compound as far as we can tell that does do some things for mood, it has very small amounts of THC. If you take a lot of a CBD preparation, you will get enough THC to turn a drug screen positive. So if you smoke marijuana, you will certainly turn a drug screen positive, probably for at least 30 days. The problem with smoking marijuana is it's such a large dose, you get a lot more side effects than you get generally with smaller doses. So THC, very dose dependent. CBD, you can take ridiculous quantities and not get any kind of side effects. You may not get any benefits either. In some cases, they're a little bit overrated. Anybody who's really trying to make a lot of claims about their product is probably overdoing it with you. And so you start small and you go slow and you see if it does something for you. It's perfect. The CBD, you can just try ridiculous quantities. It costs more than you can take a huge amount. THC, you have to be in a state where you can buy it, or you might be able to get it from a physician.
Great, thank you. Now I got to get away from you for a minute. Sarah, do you ever use CBD or medical marijuana?
I use medical marijuana.
And does it work for you?
It works for me to help me go to sleep. Not only do I have multiple sclerosis, but I also have anxiety and depression, and so I don't use it during the day because sometimes that can just make some of the symptoms worse, and it makes my functioning a lot more difficult. But to go to sleep, it has really helped me.
Great, thank you for that. All right, last question that we have. We have to get on to the COVID questions. Okay, so the last one that we're going to ask is open MRI as effective as closed?
The answer is absolutely not. If you can't fit in a regular MRI scanner, by all means, you'll have to get an open one. But if it's simply claustrophobia that is getting your way, there are lots of medications that are useful. They're in the Valium family. The most common problem is they just haven't given you enough to be able to alleviate the anxiety. If it's pain or lying down in that position, they can do that. And MRI is very important that you're comfortable and you're relaxed and you can hold still. Open scanners are in many cases in centers that aren't as good because they're cheaper to buy and they make terrible pictures, and we don't need terrible pictures of your brain if we're trying to monitor your MS. If you cannot physically fit in a regular MRI, you should get an open MRI. They should try to alleviate anxiety you have, the claustrophobia. It just takes a big dose of Valium-like medicine, like clonazepam, Xanax, diazepam, and people can get through it. And once they learn how to do it, it's not so bad.
Okay, great. Thank you for that. Again, everybody, we're not talking about medications tonight. There are a lot of people asking questions about medications. We're not here to talk about this. We are now entering our big topic of the night, all right? So I'm going to clear the screen of all the questions that are still pending. If you have anything to ask about COVID, about the vaccines, about anything that relates to coronavirus and the way that we are living it right now, now is the time for you to ask, okay? And Jill's going to take over for now. She's going to start asking questions again to both Dr. Hunter and Sarah. And by the way, later on, I'm going to come back on and I'm going to tell you how everybody can watch this again, all right? So just listen to everything, ask your questions. We're going to get through this. Just like they say, we're in this together, okay? Thank you.
Okay, guys. Dr. Hunter, are MS patients in general at greater risk for getting COVID-19?
So no, everybody gets it equally well, but the severity of it doesn't seem to be worse in people with MS than normal, as far as we can tell.
Okay, and are antiviral medications providing any help for people who get COVID-19?
Well, this is very interesting because some research has been done with interferon beta, which is Rebif, which has been used in a large U.S. trial in combination with the antiviral drug remdesivir, which is approved now for COVID. There's a very strong possibility, it looks like, that interferon also helps mitigate the severity of COVID. But this is it's not a cure, and it's not easy to get, obviously. But it is been studied.
Great, thank you. I'm going to jump off COVID for 1 second, and I just want to ask you about telehealth. Or tell us about your telehealth appointments. First of all, Sarah, have you ever tried telehealth?
I've had a few telehealth videos appointments with both my primary care physician and my neurologist, and I think on those times where I didn't have the physical issues, I didn't mind having the talk. There has been one or two where I wanted to be seen in person, so it really just depended on my needs. But whenever I have done the telehealth, it was excellent. I got all of the information out of that visit that I was looking for.
So if it wasn't a particular symptom that you were concerned about, overall in general, it was helpful.
Yeah, if it's my regular 6-month checkup and I wasn't having any issues, then I felt fine to go in. But there's been a couple of things where I did want to be seen.
And Dr. Hunter, what's your experience with telehealth? Have you been using it?
Well, we have some. The biggest obstacle has been high-speed internet isn't available to many of our patients who live in rural areas. And then the other thing is, even if it is, their technical skills for getting these interfaces operating has been a problem. So it a lot of times is reduced to the quality of a telephone connection. Neurology remains a hands-on specialty. In fact, if you're a neurologist and you can't touch your patients, you're limited. You can't tell somebody's mildly weak. You can't examine their eyes carefully. You can't see their palate. You can't do a lot of things if there's a problem. You can't carefully examine their gait over a video conference call. About all you can do is hear their voice. You can see if their hands are shaky. That's not enough. Now, if I'm just checking on how people are doing, filling medicines, writing orders, answering questions, trying to see if there's any problems, I can do that. It takes longer for me to do it in that setting. I can't get as many people helping me. I can't function as a team in that setting as effectively. So it's a necessary evil if people can't get to the office. We find for many years I've offered that service to patients, and just about everybody would rather spend a lot of money on gasoline, drive to the office, and get seen by a human being directly. But it can be done, and especially if someone's sick or they can't get there, it's better than nothing. But there's a role for it. But I hope it doesn't continue to be necessary to do it a lot.
But you would continue offering it beyond the pandemic if somebody wanted
Yeah,
it.
the insurance companies have paid for it for many years, and they pay 1/10 of what they normally do outside of this if there wasn't legislation that made them pay the same. So you got to be able to get the work paid for. As long as it gets paid for, I don't think there'll be a problem offering it.
Okay. I'm going to go back to some COVID questions. Dr. Hunter, are MS patients who use an immunosuppressant drug more at risk for getting COVID?
Well, they're not more at risk of getting it. They're more at risk of getting severe disease. Now, what immunosuppression means in MS is very different, because for practical purposes, almost all of our MS medications are not significant immunodepressants. So all these drugs are tested in people for many years, like 100,000 years many times within the first couple years of use. And so people have lots of viruses and illnesses during that time. We understand very well how people with MS respond to viruses. In practical purposes, people with MS aren't immunosuppressed. The only people who are really seriously immunosuppressed is very transient periods, like if you got one of these drugs that really wipes out your lymphocytes for a few weeks. You are immunosuppressed during that very narrow window of time. If you are on extreme amounts of long-term steroids, which is not normally what we do in MS, if you just had a chemotherapy regimen and stem cells to rescue you, you are immunosuppressed. But otherwise, you're not really immunosuppressed with MS. And viruses do not give people with MS normally more problems than everybody else.
Okay, thank you. Great. There are some particular drugs that may be more problematic? I know a lot of people have asked about Ocrevus and timing of that infusion with timing of vaccines. So would that be more problematic?
That is a very good point, Jill. And so here's the thing. Ocrevus, what it takes away is a part of your immune system you don't really need very much after you're an adult. It's used to build your immune system. When you give a vaccine, you're building someone's immune system. You're teaching it how to go after something. One of the components of that is making antibodies. The other is making T cells. Now, Ocrevus short circuits making new antibodies that you haven't made before. And that, when that drug is circulating, it will nearly completely block that effect. And this has been tested with Ocrevus. And we know that things that are like what you've seen before, like the flu vaccine or the tetanus shot, you still respond to. Not quite the same, but it's a meaningful response. but things you've never seen before, you don't respond well to. So we recommend with a medicine like Ocrevus or Limtrada that you use it a couple months, at least 3 if possible, after you get that vaccine, at least 3 months after you got a treatment, because then the medicine is not circulating anymore and your body has a better chance of creating a meaningful response. I also recommend that right now the vaccines that are available that come in the freezer, these are not live virus vaccines. They are chemical vaccines. They're the ones that are available called mRNA. They're revolutionary technology. These are safe. One of the vaccines that's coming is an engineered live virus that's going to be very popular because they can keep it in a refrigerator and in doctors' offices and pass it out to everybody without having to keep it in a hardcore freezer and thaw it out. People who are on stronger medicines, Ocrevus, related medicines, Limtrada, recently gotten other chemotherapy type regimens, they should not take live virus vaccines, and that extends to the ones that are like Gilenya and even possibly Tecfidera, and its family. So those live viruses, we just don't know if there's somebody that's going to have a bad reaction to it. And in general, MS patients, there's very few live virus vaccines. We have enough data to know it's safe to use. So that's something you have to discuss with the physician. But the ones that are not live viruses, which is almost all vaccines with just a couple exceptions, are safe in people with MS. It's just in certain medicines you may not respond well to it. That's okay. If everybody else got it too, you're not going to get it.
So people are concerned about side effects from the vaccine. And if it's flu-like symptoms, would they be similar to flu-like symptoms that may have come from an injectable?
Yes, they're very similar because it's the same response in your body. But the flu-like symptoms, if you've had a tetanus shot multiple times, you know what these are like: sore arm, achy, tired, feverish feeling. That's what you're looking at.
So people with MS should not be more hesitant about getting the vaccine?
The benefits of the vaccine so far outweigh the risks that they've literally given these drugs to 100,000 people and had what's essentially a trivial number of dramatic reactions. So it is not anything that normally you'd worry about.
Sarah, how do you feel about getting a vaccine?
I feel 100,000 people have had it so far with minimal side effects, so I feel pretty good about it. And whenever I have the opportunity to take it, then I think I'm ready. Now, of course, if there's any information that comes out between then and now, I'll make a different decision possibly, but I don't see that outcome happening. I'm very hopeful and looking forward to it doing what it's supposed to.
I think you've had some personal experience with some close relatives getting the COVID virus, and how has that impacted you?
Well, it's kind of weird because it's been in my house 2 times now. In March and April, my entire family, my ex-husband and my 2 children, were extremely sick for 7 weeks, to the points where their fingernails had turned color. They were extremely sick, but we didn't have access to the COVID vaccine then, or not the vaccine, the COVID test, so we don't definitively know, but I'm not really sure what else would cause them to be sick. They tested negative for flu. And taking care of them during that time was extremely difficult, extremely stressful. I was very worried, but I never got sick from that time, and I was able to kind of be everybody and do everything during that time. So it really pulled us all together. And then this last time, my ex-husband was actually diagnosed because he did have access, and his symptoms this time were much more milder, a lot of fatigue, but he's able to function now that he's out of quarantine much better than he could before. So where I stand on it is I've had it in my house twice now. I still haven't gotten it. I'm pretty darn lucky. that doesn't mean I'm going to be careless with my actions, but it's going to mean that I'm going to be thankful for what I've had so far.
Okay, excuse me one second. I'm getting messages. In the hierarchy, Dr. Hunter, of people getting the vaccine, where do MS patients fall? Do you have a clue?
Yeah, they pretty much fall according to their age, and so most anybody who's an older age or institutionalized is first up in the list. It depends on the state. The states set the rules individually, but usually it's going something like 70 years and up or institutionalized. They're going to get it first after the doctors do. The doctors and the healthcare professionals who they're trying very hard to make sure. I mean, they called up everybody in the county and said, "We've got vaccine for you who works in an institution or is licensed." I already had it. It's painless vaccine. It's one of the simplest things. The biggest thing is you have to wait for them to thaw it, because they have to thaw it when they're ready to use it. However, it's a good system. It's going to take some time to get it out to everybody. This disease, I will say, and I don't mean to scare people, but I think the media has hid how bad this really is from a lot of people, because the odds are similar to dying when you're over 50 to throwing snake eyes at the casino. I mean, it's really a very substantial risk. And there really, as far as MS patients goes, there isn't any MS medicine that's that dangerous, except maybe Tysabri, in people who've been taking it a while. So it's most people do fine, but you don't know who's going to do badly. And it's very welcome that we have this vaccine. I wish it would have been here 3 months before. Maybe next time this goes down, they'll be a little smarter about it. But it's really important, and that you and everybody around you get this vaccine, just like it is for the seasonal flu vaccine. But the seasonal flu vaccine isn't a third as good as this vaccine. It's much less effective.
What is the after someone is vaccinated? What is the protocol for continuing to wear a mask and continuing to social distance? How are people treating that?
Well, not enough people are out there, so everybody still wears masks because they don't have to explain that they're immune. And it really does take a number of weeks to get up to immunity. It probably takes at least a month for half the people, and probably 2 for everybody to get there. 90%. And you don't have to be completely immune, because even if you get it, it's going to be a lot milder after you're vaccinated.
Okay. But are they recommending, or would you recommend people still wear a mask?
I would recommend wearing a mask, because everybody's going to get nervous about you if you don't. The benefit to masks is modest, really. It's quite modest. The kind of masks that really work well, most people don't wear because they're very uncomfortable and they have side effects. So they're usually worn in healthcare settings simply because they're very high risk. There's so much virus in the air that if they don't wear them, they're going to get sick.
Okay, Sarah, do you have any thoughts about mask wearing?
I wear mine every time I go to work. It doesn't bother me. I'm used to it. I like the disposables over the cloth. That's my own personal preference. I like them to have a little design. I wear them. I feel safe. I feel comfortable. I think the more that we wear them, the more used to it we get, and that's what I found. I have no issues wearing my mask.
Great. Okay, I think we're going to switch off to Stuart now and see if he has any questions.
My gosh, you're asking that again? You're saying that again? Of course we have questions. Here we go. You ready? First, though, I want to say that, Doctor, when you were talking about the mask wearing, I personally have gotten a supply way back in January when I first heard that this was even happening in China. I got a supply of KN95s from the USA, okay, 5-ply. And yes, they're extremely difficult to breathe with. I find that if I'm wearing them even in the supermarket, I get to a point where I'm just feeling faint. I mean, it's hard, it's difficult to breathe, but at least I know I'm safe. It's not just, what I'm doing and keeping others from not getting my my spray, but I just feel totally safe walking around with that on, and I've got, I don't know, like 20 more to go, so I'm in good shape here. All right.
They work really well. They're just very hard to wear.
Very hard to wear, and stifling, like I said, like you want to find a corner of the store that you're in just so you can lift it up for a minute and get some good fresh air coming in, because it's just difficult. All right.
Well, I worked during another pandemic, 30 years ago, and my solution was to hyperventilate before I went into a room and hold my breath. Yeah. I can't do that all day long.
Right.
And Stuart, I just want to say I am traveling. Normally, I wear just a really light cloth,
right.
The disposable. But because I'm traveling right now, my niece, who is a nurse, gave me this mask, and it was hard. It was really difficult. So I really appreciate all of those who work all day in these.
That's right. Very safe, though. It's much better. It would be better if everybody wore one instead of wearing those things that they pull up over their face, and those dragon masks or whatever they're called. All right, so let me get back into the questions. We do have several. I am going to loop some of them together because they can be. So the first one being that a person wants to know, and several others have asked similar questions, and that is that, can they take a shingles vaccine or a flu vaccine or some other vaccine at the same time that they're taking a COVID vaccine, or should they space it out, and how far if yes?
Well, that's a good question. They're not going to let you take the COVID vaccine if you've had another recent vaccine. The reason is they don't want, they want to be sure that you aren't having side effects from this vaccine. Is there theoretically any problem? Our buddies in the military line up a platoon of soldiers and give them 10 vaccines at once. They feel really bad for a couple days. But is it dangerous? Probably not. Now, shingles vaccine comes in two forms. The older one is a live virus. I don't recommend people on stronger MS medicines get that. Because it's not known to be safe. The new shingles vaccine called Shingrix, which is 2 doses, is not a live virus. It is safe to get. I wouldn't have a problem with combining that with any other vaccine, but you're going to have trouble that they're going to screen you when you go into the COVID vaccine. If you've had another vaccine, they're going to do that. And when you go in to get any of these other vaccines, they're going to ask you if you had another vaccine. So there are certain ones, unless the pharmacist has given them, I wouldn't try to get more than one at a time. The vaccines that everybody with MS needs to have as an adult. There is a vaccine that if you're an adult now, you may not have gotten as a child because it's recent, called Prevnar 13, which is a very powerful pneumonia vaccine that prevents a lot of other kinds of strep. And it's given multiple times to children now. It has tremendously reduced serious illness in children. You need just one dose as an adult. You need a dose of the childhood tetanus vaccine called DPT, which is the pertussis vaccine as an adult. Because as you get older, your immunity wears off to pertussis, and it's a very unpleasant illness to get. You need, once you're well into your 50s or early 60s, you need the shingles vaccine. And then as you get over 65, you need what's called Pneumovax 23, which is another pneumonia vaccine. You get that every few years.
Okay. Thank you for those answers. Now, for everybody that's sitting here saying, how am I going to remember what he just said? The answer is you don't have to. All right. Here's what's going to happen. And before I get to the next question, I just want to let everybody know that, yes, like every event that we do, this is being video recorded. Okay. And like every event that we do, it will get onto our YouTube channel. Yes, MS Views the News has our own learning channel on YouTube, and you can access it from our website, from our blog, from our email newsletter. You can find it on social media. Things are announced all the time. All right. So you can contact me if you need to. And if you say, what's your email? I'm going to shoot you because you got a zillion emails from me already. All right. And I'm not even going to say it. So you got it, and you can just write to me. All right. So next, let's get to Stanzi's question. So Stanzi is asking about the different DMTs if there's any one of the DMTs that cannot. Stenzi's asking about specific DMT, but there are others that have asked about their DMTs that they're using. Is there any DMT that should not be? Is there any person using a DMT that should not get coronavirus vaccine?
That's a good question. The answer is we don't know, but we don't think there's a reason not to get it. The problem is we don't know how well it will work. We know that vaccine studies have been done with most of our DMTs, and most of our DMTs, with the exception of Ocrevus, people have good responses. There's a related medicine that was just approved called Kesimpta, and there's Rituxan, which are related to Ocrevus. We would expect they have the same problems. With Lemtrada, there's in the first 2 months, people don't have, after they get the drug, they don't have normal vaccine responses, but by 3 months, it's normal after that. So there's no reason they can't. We know with Gilenya and Tecfidera and that family of medicines, and Rebif and glatiramer acetate, that family of medicines, that they respond perfectly normally to vaccines.
Great, thank you for that. So on to another thing, and so many people are like, why don't we know? All right, number one, before we get into why we don't know and what we do know, please everybody do know that there's a thing that was put together called CoVMS. And this was by the National MS Society, the Consortium of Multiple Sclerosis Centers, and the MS Society of Canada. All right, and they are documenting what is happening with MS patients who are contracting coronavirus, all right? And what's happening with some, and if there are any deaths, and so on and so forth. The registry is easily available. Where? Our website. It's that simple, all right? When you open up the MS Views and News website, it is right there in the center. It says CoVMS. Click on the link that's provided, go visit the registry, and see what's listed there. But going back to something else, Dr. Hunter, I've asked you this question, and I've asked others about it as well, and I just want you to, give your answer to the audience. Have there been were there any MS patients in the studies that Pfizer, Moderna, Novavax, this one or that one were doing?
The first time you do any kind of major trial, you exclude everybody with other major health problems from the study. That's normal operating procedures. The government sometimes asks for studies subsequently that address certain issues, like how well people do with certain kinds of conditions. These will be done. That information comes later. In general, people with MS through many, many years there's many studies that have been done about vaccinations in people with MS. Vaccines seem in general not to be a problem with MS, and to actually protect people from MS relapses in general. There was actually, the tetanus shot was actually patented for the purpose of treating MS because there was data that it did this, and many of these studies were done because people came down with MS close to getting a vaccine, and so they thought, oh, it must cause MS, and careful investigation statistically shows it just happens about as often as it should, just by chance.
Great, thank you for that. And another thing is that a lot of people are asking, when would it be best for them to get their shingles or their flu vaccine? And before you even answer, I just want to say, why wait to get it? If you know you have to wait a period of time to get the COVID vaccine, then get the other one now, and then you'll be good in 2 months from now to get the other, right? Is that similar?
30 days is fine. Yeah, 30 days is enough time to generate a substantial immune response to a vaccine and not worry that there's any interaction. Most of the common vaccines, like the pneumonia vaccine and the flu vaccine, can be given at the same time. The shingles vaccine and the flu vaccine. As some pharmacists might worry about the pneumonia vaccine. That'll give you some fluish symptoms and a sore arm, because that's your immune system saying, "Hey, there's something here. It's not supposed to be here."
Okay, great. Thank you for that. By the way, for those that don't know me, I see there are a lot of new faces online. My name is Stuart Schlossman. I'm president and founder of MS Views and News. I too have multiple sclerosis. I have been doing MS events live in person across the country for many years. Last year, we were on the road for over 160 nights doing educational programs. This year, we were on track to do the same thing. Instead, we got tied down with COVID. We turned it very easily into virtual programs, which we were doing ahead of time, and that we have been doing for the last few years. So it was very easy for us to do this. If our schedule was tedious this year, we're doing still 50 plus educational programs virtually. I want to let you all know, next year, oh my gosh, we are going to be doing 8 to 10 programs per month. Okay, per month. You will be seeing me online 5 to 6 times per month, and then doing these events. And we have a slew of new programs that we are going to be doing that relate to COVID, that relate to the MS community, about MS issues alone. We have wellness programs. We have programs that are going to be for people that live specifically in underserved communities. We have things that are specifically for patient wellness, all different things that are happening right now, okay? So I just wanted to let you know about that. Our next program, before everybody starts getting off of here, and I'm sorry for this, but before we get off of here, I just want to let you know that that we have a program coming up next Thursday. That's January 7th. Then we have that's with Megan Weigel. Then we have Saturday afternoon, lunchtime, with Aaron Boster. Sunday, we're doing a hybrid program, okay? We're going to be here in Central Florida doing a small in-person program. Everybody's going to be masked. Everybody's going to be socially distanced. Only 4 people per table at a big table. They will be 6 feet apart at those round tables. Those tables will be placed 15 to 20 feet apart. Our speakers will be far away. We will not have a closed environment. There will be all open doors to the room so we can have good airflow in the room. We have done this before. We did this in Roanoke in August. We did this in Columbus, Ohio in October. We are doing it again, and we are going to try to do more of these as we go into 2021. All right? Just please know that MS Views and News is the leading organization in providing virtual programs and in-person educational programs. We are going to continue to do this. That is what we do, okay? So just, bear with us, know that it's happening. Look at our website, go to the right side of the page. There's a list of programs there. All right, following the one with Dr. Boster on the 10th, we have the 12th with a social worker. We have the 18th with Dr. Ben Thrower. I think it's the 18th. We have the 27th of the month with somebody from the National Multiple Sclerosis Society to find out all the things that they are doing. And then in February, it flips, and we're adding more programs in February. We're adding a program with me and Damian Washington where we are going to be bringing in all different people, the different patients to speak with everybody, crisscrossing back and forth across the country, but virtually. Okay, and again, that's all I can say is we're going to bring everything that we can. We're going to have expert speakers like Dr. Hunter, Dr. Boster, Dr. Thrower, Megan Weigel, this one and that one, Mitzi Williams. I mean, it's going to be what a year we are going to have in 2021 to make sure that you are educated as best we possibly can. All right, there are a couple more questions remaining for tonight, all right? And then we're going to say goodnight to everybody. And before we do, though, I want to make sure that I personally am going to wish you all a very happy holiday season. Make sure that you stay safe. Wear the damn mask like everybody else is saying, all right? Wear the damn mask and be healthy for yourself. And it's not just for yourself, it's for your families, all right? So everybody that you come in contact with, make sure that you do not come in contact with anybody not wearing a mask. You see a person coming towards you not wearing a mask, step away. Be safe. Those runners that are running by you, well, they're huffing and puffing, and what's coming out of their mouths as they are, who the hell knows, all right? Be safe, okay? All right, let's get to the last few questions here, and then I'm going to say goodnight to everybody. So, Diana, listen, we already answered that about, we answered about medications and COVID, all right? We're not getting into that again. All right, Mike, thank you for that. He's saying great program like usual. Great webinar. Thanks for everything we do. All right, Coy, yes, yeah, thank you for your kudos. All right, where's the next question? I've had allergic reactions to medications. Will that be the same with COVID vaccine? What kind of allergic reactions might I be looking for? This is Stacy. Doctor, can you answer that?
That's a good question. So let me tell you, there are some people who have serious allergic reactions to many vaccines. Those people are different. They are not the normal person. The average person knows that they haven't had this. I mean, if you just had normal sort of medicine intolerance or, a rash with some pills sometime you took, this is not for you to worry about. Vaccine components are basically the same as what your body makes all the time. Every cell in your body has this chemicals in it. It is just program. It is a program on how to make the part of the virus. That's all it is. Now, some people have dramatic reactions to things, but they have dramatic reaction to lots of things. And those are the only people that they don't want to get this vaccine. You should talk to a doctor before you get that. You've got months to do that, especially if you're a younger person. But you need not be worried. I mean, anytime you go to get a vaccine, you should make sure you ate, that you drank plenty of fluids that day. That's about all that you need to do to be prepared for a vaccine. They give these many vaccines they give to people who are very sick, who are very young, who are very old. And this vaccine is a technology that's revolutionary. It will get a Nobel Prize this next year, almost for sure, because it's quite an interesting story when you read the story of how this vaccine came along. There were thousands of people who told the person who developed the technology that it wouldn't work and they should go away. And they're going to get the Nobel Prize, and it's going to change the world forever.
Great, thank you for that. Now, next interesting question. A person wants to know what if a COVID vaccine can be taken for a person that had Bell's palsy or Guillain-Barré.
Well, people with Guillain-Barré, in most cases, it's not a problem to get other vaccines. There are a very tiny number of people to one of the flu vaccines one year who got Guillain-Barré, and there is a system that was set up because of that to help people who have very severe reactions to vaccines. This is a very tiny number of people. So normally Bell's palsy or Guillain-Barré would not be a reason not to get the vaccine. And this vaccine, as long as you're not on a stronger immune medicine, you can get any of the vaccines. If you're on something that's a stronger immune medicine, Lemtrada, Ocrevus, Gilenya, Tecfidera, you shouldn't get the live virus vaccine that's COVID. It's not here yet. It will be here in a month or so. It's in Britain. It's a single-shot vaccine. As long as you get one of the frozen mRNA vaccines, there's no worry about that.
Great. And can you tell us the differences between the vaccines, especially those that are available right now?
Sure. The two that are approved already in the United States are called mRNA vaccines. They are basically the genetic code for making a piece of the virus. And your cells take up a little bit of this, and it's enough to teach the immune system how to find the virus, because it knows it's not supposed to be there. Makes your arm a little bit sore. And then they're almost identical, these two vaccines. They're stored frozen because they're not stable if they're in liquid. The other vaccine is an engineered virus. It's called the Astrazeneca vaccine. So the first two are called the Pfizer, and the other one is called the Moderna vaccine. They're virtually the same vaccine. The Pfizer is given every 3 weeks for 2 doses, and every 4 weeks for the Moderna. That's just how they're given. The AstraZeneca vaccine, that's the next one coming down the pike, it is basically an engineered cold virus that's very wimpy, that they put a piece of the COVID virus into to teach the immune system how to go after it. And it works quite well too, and it's a single dose, and it's stored in a refrigerator, which gives it a lot of advantages. And it will be available, within 6 weeks for sure.
Great. Thank you for that. Sarah, I don't mean not to ask any questions, but we only have the last few are for the doctor, okay? So there are several people, doctor, that are still like contesting or asking why MS is not a priority. Can you please tell them in like 30 seconds why it's not a priority to be given the vaccine right now?
Because they don't seem to be at higher risk. The things that will be the priorities are age and the presence of heart or lung disease, because those are very powerful determinants of severe disease and death with the virus. And there is not enough vaccine to go around, and they will do what's traditionally done in medicine, which is start with the people who need it most, which is called triage. That's why some people wait longer than others in emergency departments, because people will die if you don't do that. And I think it took way longer to get this vaccine here than it should have, and that wasn't because of the science. That was because of the bureaucracy in the government. And it needs to get out there. And the big holdup right now is the bureaucracy in the states, because our government, deferred to the governors who aren't always so careful. And excuse the political dialogue, but our governors have not been lickety-split and the smartest knives in the drawer to get this done fast. But right now, the bottleneck is really just how much vaccine is available, and they're making it really fast.
Okay, great. Thank you for that. So we are at the point now where we are going to say Happy New Year to everybody. And I want to thank Dr. Hunter. I want to thank Sarah. I want to thank Jill for being part of this program. We could not possibly have done this program without you. And for everybody watching, we definitely could not have done this program without you. Please stay in tune with MS Views and News for all that we are doing. Please also remember our video producer, Bill Shanley. All right, Bill, great job. He puts together all these things with us. We're here at his studio. All right, this is where we do our virtual programs. I come up to Central Florida every 7 to 10 days these days since this whole thing began. It's great. I'm still getting out of town. All right, this is a LED wall behind me, and this we can change all the time. We can make it different colors. We can put different backgrounds on there. We can make it look like I'm skiing in the Alps, all right, and doing a program, all right. But we use this wall. We use his studio. If anybody is down here or wants to hire him for being somewhere else, I'm going to let you know this guy is class act, all right? And it's not that because he works with me, but he's working with some really big companies here, and he's like taking us on as a charity type of thing, all right? But Bill's been doing this with me for almost 10 years, and or not with me, but with even me and MS Views and News, all right? And so I give him great kudos for doing all that he does for us and our programs. So again, this will be published onto our YouTube channel, hopefully within the week, all right? And then you'll be able to look at it again, share it with your family and friends. But for now, again, I want to say thank you for everybody who does follow MS Views and News throughout the year. Please tell your friends, all those people that are not following us, make sure that you're telling them that they need to follow us. This is a patient-based organization that does for MS patients what we know needs to be gotten to you. So we're going to keep on doing this. Again, Sarah, thank you for being here. Jill, thank you for being here. Dr. Hunter, always a pleasure. I miss coming to Tennessee, and we're going to do that again soon. I can't wait to get vaccinated so I can get out there again. All right? Thank you, everybody, and good night.
Good night.
Good night.